Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. With me this week, I have another legend. It is Dr. Patrick Agnew. He is from Virginia Beach in Virginia, and we're not going to hold him up too long today because he is going surfing this afternoon. But Patrick, if you recognize the name, he was on episode 373 titled Podiatry Student Recruitment, Research and Unity, and that was with Dr. Ben Pearl and Dr. Patrick here, who's also was on the podcast a couple of weeks ago. So after talking with Patrick on that particular episode, I wanted him to come back on because he had I thought, a really interesting career, from being involved in the early developments of podiatry pediatrics to his military service in the United States Navy, serving in Desert Storm and Desert Shield. And I could go on, but Patrick, I'm going to let you tell your story. So welcome back to the Podiatry Legends podcast.
Thanks for the invitation. I had a lot of fun last time. That was a remarkable group you put together for that conversation. I did a whole lot more listening than talking.
Yeah.
I guess it's my turn to talk more.
My first question is, I like to ask a lot of people, what got you interested in this crazy profession in the first place?
Excellent question. And I get to answer that almost every day. I was always interested in medicine, thought it would be worth. I was an undergraduate. I actually was a marine biology
Okay.
undergraduate, and I did that for fun because I knew I could take my biology, chemistry, math, and physics and still drive a Zodiac around the Haven Inlet and scuba dive and do fun stuff. But I didn't really know which sort of specialty in medicine I would want to do. I drove an ambulance all through college, and I worked in the emergency room at a local hospital. And I got to see a lot of different professions and what they
Mm.
did. And I got a little scared. A lot of the guys, a lot of the doctors seemed to be very unhappy. It seemed like there were not only divorces, but a lot of drinking, maybe some other bad habits.
Yeah.
And I got a little scared about medicine in general. And I was wondering, what's wrong with this? Why do so many people seem to succumb to those sort of problems? And I realized that it wasn't the medicine itself, but some of the demands in the different specialties seemed to be really unreasonable. It was just expected that you weren't going to get any sleep. You were going to be called at the most inconvenient times. And I was talking to my college guidance counselor. Well, I found out later we were both competing for spots in the same medical school. He was a graduate student. He was my guidance counselor, so he may have had some additional agenda in giving me advice. But he said, "Why don't you look into dentistry?" And I said, "That looks like it's even worse." And he said, "Well, how about podiatry?" And I said, "What's that?" And
Yep.
he arranged for a visit with a local podiatrist and Dr. John D'Amelio, and I spent a day with him. And he seemed like the happiest guy I'd ever met in medicine. And I saw all the different things he did through the course of that day. And I realized, gosh, this is like a best kept secret. In the 4 hours I was there, he was doing orthopedics, he was doing dermatology, he was a vascular specialist.
So many podiatrists that have come on this podcast mention how they went and saw a podiatrist, for example, or they shadowed a podiatrist, and they said the same thing. This is like the best kept secret they'd ever heard of. The person actually enjoyed the job, wasn't being called out after hours, had a great relationship with their patients. And I think this is really important for anyone who has another person come into your room to learn about podiatry. If you are not giving them the most positive experience, please don't take them into your room. If you're one of those miserable podiatrists, which I don't assume they listen to this podcast anyway, but if you're miserable, please do not let school students or anybody else who's thinking about doing podiatry in your clinic. Just let them go and see somebody else. But I think that also applies when people first graduate. If they end up working somewhere and that person is a little bit miserable, I think in your first few years, it's really important to make sure that you have a positive experience in those first few years. If you've got a really negative boss, change jobs before you change professions. That's what I reckon.
That sounds like great advice. I'm actually the American Podiatric Medical Association Council on Podiatric Medicine. So they have a referral network where interested students can link up with doctors in their community, and have experiences like coattailing in an office. And I've met a lot of really neat kids like that. One of our new interns that just started our residency a couple weeks ago actually came and visited with me early in her college career and decided to become a podiatrist.
Yeah.
Now she's a podiatrist and she's one of our surgery residents.
Yeah. When I was in the UK in Liverpool doing a talk at the Foot and Ankle Show, and there was a young girl there who came up to me and she said, I just want to let you know, I used to live in Australia and I came and saw you when I was like 10 or 11 as a patient. That visit and that whole experience I went through with all my treatments, she goes, it was so positive that I said from that day, I want to be a podiatrist. And that's how she got into it.
You did a good thing.
Yeah. It's amazing the impact can actually have on people with what we do.
Well, I think that physicians had an impact on my development. I've broken about 13 bones. I've had about 100 stitches.
Yeah.
I was a reckless, wild kid, surfing, biking, skating, playing hockey, everything. I got hurt a lot. I was too little, probably, or just not talented enough for some of these things. And usually I'd be laying there in the emergency room, and then the doctor would come in as the hero that was going to put a cast on my arm and let me go home. And I think, I don't know what percentage of doctors had medical experiences as a child, but I'm sure it's formative. And I
Yeah.
tell you, I haven't been disappointed at all.
Yeah. I never even thought about podiatry or never even thought about anything in healthcare because I played tons of sport, never got hurt. I just never got hurt. I was like rubber. I just bounced. So I never had to go to a doctor. I never had to see a physiotherapist. I never saw anything except a dentist. So my brother ended up becoming a dentist. And that was the first exposure that, oh, you could do something in healthcare. And then, fortunately, a good friend of mine, or a guy I went through school with from grade one all the way through the end of high school, he went off and did podiatry. And I went back, repeated grade 12 because I had no idea what I was going to do. And that's how I was exposed to it.
Well, I'm guessing like me, you weren't disappointed. I knew what I was going to be when I started. You're not up to the vagaries of some kind of a match and
Mm,
might wind up in some specialty you don't really like. I knew where I was going, and it was pretty wide open field. I mean, podiatrists, I guess, are the last surgeons to leave the barber shop, and we still, when I graduated in 1986, it seemed a little Wild West.
yeah.
A lot of the things we were doing, we were learning through almost folklore. We weren't deep enough yet into evidence-based medicine, and our curriculum was getting closer and closer to allopathic medical school, but it wasn't quite there yet. But there was a lot of uncharted territory. So when I got out into practice, I had done my residency with Dr. James Ganley, who was one of the founders of the American College of Foot and Ankle Pediatrics. And he had learned orthopedic surgery working next to a Dr. Bunden's at the Naval Hospital in Philadelphia. He was an enlisted man, and Dr. Bunden's took him into his clinic and knowing that he was already a doctor of podiatry and there wasn't really an officer commissioning program for doctors of podiatry.
Yeah.
So he went as enlisted and worked with Dr. Bunden's and learned orthopedic surgery. And then he took those skills, opened his own practice, and part of that practice was working at a state hospital, which used to be all over the United States. And these were hospitals where people with severe physical and mental disabilities would be interned. They would live their lives there, and he would try to help. He'd try to take these very disabled children and get them to the point where they could walk, or at least get them where they could sit in a wheelchair straight. And
Yeah.
he exercised these skills.
So was it that aspect of seeing that where you could take a child who couldn't walk to being able to make such a life-changing experience for them?
That had a huge effect on me. Driving an ambulance, working in the emergency room, I witnessed a lot of heroics.
Yeah.
My very first night on the job in the emergency room, I was the thumper on the code team. I was doing chest compressions on an old farmer who had keeled over on his field, and they brought him to the hospital. Although he was dead, he
Yeah.
really didn't have a chance of survival. But we went ahead and did compressions. I could still see that guy's face in my mind, but just the watching the people working around me and the real adventure of making huge changes in people's lives was very exciting to me. And to be able to do that, even just working on a relatively humble organ like the foot was something that I pursued. So yeah, I gravitated toward things like reconstructive surgery, pediatric birth defects, and things that I guess pushed the edge of the envelope in podiatry. And I was certainly offered those opportunities. It seemed like there were no boundaries, and it still seems that way.
And there weren't a lot of
Um,
people doing it at the time.
no, still not. Still, pediatrics is a small group. I am on the board of directors of the American College of Foot and Ankle Pediatrics, as has been Dr. DeHeer. And we have our national meeting coming up in September, by the way, and we always do it at a national park. This one will be at Estes National Park in Colorado, but we've been to the Everglades, we've been to the Badlands in South Dakota. We go all around the country to these national parks. We usually spend a day exploring, and then we spend 2.5 days studying like crazy and spending 12 hours in a conference room. And it's a great group of people, but a fairly small one still.
Yeah. And when you say a
I
small
think a
group,
lot,
how many people is that you're talking about?
yeah. So we'll often at that meeting get anywhere from 100 to 300 people. At the max I've ever seen is pushing 300.
Okay.
And the number of members of the American College of Foot and Ankle Pediatrics kind of vacillates in that range. Out of the many podiatrists in the United States, it is a relatively small group. We talk a lot about how I think a lot of podiatrists are intimidated by pediatrics, and
What
that
do you think that is?
maybe well, it might not be an unhealthy reaction. I mean, the
Yeah.
consequences of failure are pretty grave. You do have liability for 21 years, and if at any time during childhood a problem is discovered, that's legally actionable all the way until the child's an adult, unlike adult care. Also, who would want to hurt a kid? I mean,
Oh,
Jesus said, as bad as we are, at least we're good to our kids. I think immediately after that, he said, but even a dog's good to his kids. It was a left-handed compliment, but we do, no one wants to hurt a child.
yeah.
So people get intimidated by that. But there are opportunities for increasing knowledge, even past podiatry school and past residency, for those who are interested.
Have you travel overseas doing this as well?
Haven't had an American College of Foot and Ankle Pediatrics meeting overseas, but I've traveled overseas with the United States military and done
Yeah.
medical care for all ages.
With the pediatrics, you're still heavily involved in that now, aren't you?
Yes. Yep. I still write some things and lecture pretty regularly. I'll be one of the speakers at the meeting in Colorado again. Of course, I think that's how they get a double deal out of me. I've got to be there for the board meeting anyhow, so they
Yeah.
say, well, you have to work also. And
That's
I
fair enough.
enjoyed that. I love lecturing and writing because it challenges my premises. I have my opinions on things, and sadly, a lot of pediatrics is opinion. The amount of real evidence-based medicine in foot and ankle pediatrics is limited. You're never going to find a good control group. No mother wants her child to be in the control group.
Yeah.
Again, nobody wants to hurt a child. Our institutional review boards and our research designs have to be especially carefully crafted to protect the innocent. And so pediatric foot and ankle care is based more on opinion than real scientific fact. Also, a lot of the things that we see in pediatrics may not be consequential until a patient is an adult. We want to do the right things while the patient's young and our opportunity for excellence is there, but we may not know the fruits of our labor while still in practice or even while still alive. The
Mm.
consequences may be 20, 30, 40 years down the road. But that also makes it interesting. It's, again, a wide open field. Any new knowledge brought there is precious because there is so little already in existence. There are a lot of opinions out there. And when
Yeah.
someone forms an opinion about pediatrics, they'll defend it like a jihad. They're like, this is the law. And I'll say, well, prove it. Show me the data that supports your opinion. The
Mm.
first thing I tell parents when I meet parents of of a pediatric patient is that, look, I've read everything on pediatrics for 40 years in several different languages, and I don't know the answers. I know my opinions. I know the facts that are out there, and there aren't enough facts to tell for sure what's going to happen with your child, or whether or
Yeah.
not treatment is indicated, what the consequences of those treatment are going to be. But in my experience, and from the amount of data that is available, here's my recommendation. Now, and I also tell them if you go to another provider, which I encourage second opinions always,
Yeah.
if you go to another provider and they tell you they know what's best for your child, you should run the other direction. They're telling you their opinion, but they're selling it as fact. And I think that's wrong. I think we really need to be humble and honest with our patients about what we do and don't know.
So many little nuggets that I could pull out from what you were just saying then. One about, yeah, we all have opinions. And I used to say the same thing to patients when they say, what should I do? I go, well, from my experience and what I've worked out, treating other patients, this is what I think will be best. And if they said to me, oh, can you guarantee that'll work? I go, no. I said, I can tell you what next week's lotto numbers are going to be, but I can't guarantee that's what they're going to be. This is just, like I said, it's my opinion. But I like how you've been doing this most of your career and how you get together at these meetings and you still openly just admit you don't know everything. And I get really annoyed when I'll see a podiatrist who will stand up and they try and pretend they're the expert in a particular area, and they just, with confidence, I mean, with a hell of a lot of confidence, they get up and just blurt out their opinions on everything, but they say it in such a manner that they scare a lot of the new and younger graduates thinking, oh, that must be the right way to do it because they banged their chest when they did it. And they have a little bit of aggressive tone in their voice. So they must be right. But that's not always the case.
So that's a big red white flag there, big scary behavior, and it's hubris and can be dangerous.
Yeah, well, you'll
Um,
see them on Facebook where somebody will post a comment and you might look and go, yeah, I don't think it's exactly right. You see these polite comments coming through, and then you see these just twats, just all of a sudden, and they'll post 4 different references of different articles and really just almost humiliate that person. And I'm thinking, yeah, you could have just sent them a private message to do that. Didn't have to be in an open forum.
I appreciate the passion, but I
Yeah.
also admire humility. And
The other part I thought you said was really good is when you go to these events and you like talking and you like writing because it forces you out of your comfort zone a little bit. They tell me if this happens with you, but when I wrote It's No Secret There's Money in Podiatry, and the funny part is that book's not about making money. I said to this other author, can I ask you a question? With all the time and effort and research I put into writing that book, I feel a lot smarter by doing that. And he went, yeah, you do, because you can't just say something without checking the facts. But I found the same thing every time I write a blog article. Anything, I feel better for the process.
just the process of trying to explain something to someone else deepens your understanding. That might have been Ben Franklin. There's a quote there. I'll have to look up, but I had the blessing of founding a residency program here at our medical school 25 years ago. And that was a relatively rare thing for a podiatry residency to be in a big regional allopathic medical school like
Mm.
Eastern Virginia Medical School. And I had, thank God, the initiative and the guidance of Dr. Kieran Mann, who was a professor of surgery. He was the chief of surgery at Temple University when I was a student. And he became aware of a grant program through the United States government to start new residencies. He called me up and he said, Patrick, would you like to start a residency? I said, absolutely. Yeah, I can't wait. And it was a lot of work. I remember faxing paperwork to the Council on Podiatric Medical Education from the nursing station as my youngest son was being born down the hall of the hospital. So we had so much paperwork to do. But the my residents and my students think that I'm teaching them for their benefit.
Yeah.
It's a big charade. Okay. I'm teaching them to reinforce my knowledge and hang around these brilliant young people. These kids are so smart. I would not be able to get my own residency now. I wasn't a smart enough student to get my residency program that's so competitive. We get a couple of hundred applicants for each spot. and they're top notch in their classes. And these kids, just being around these kids, I hope I absorb some of their knowledge and intelligence just through osmosis and being near them. But I practice, I guess, a lot of Socratic teaching. I ask them a question, and
Yeah.
they think I'm asking the question because I want to know if they know the answer. I want to know. I want them to give me the answer. I want them to teach me.
I will admit that when I have a clinic, and we'd always have at least one or two students come through every year who are like in their final year and they're thinking about what they're going to do. And our goal was always make sure they have a fantastic experience. One, not just because were we looking to employ somebody, but I wanted them to say, this is what a really good clinic looks like. This is what, if you ever have your own clinic, try and make it better than mine, because then that is going to be fantastic. But I would ask them a lot of questions and they would be answering stuff and I'm going, wow, I didn't know that. It's actually really interesting. And that's the thing. And that's why I always think it's great. You're always on that path of learning, even though now I'm not in a clinical situation. I talk a lot more about business and marketing. I probably read more marketing books than anybody else, or business books, because every time I pick up a book and read it, I'm always learning something new. If I was still in a clinical situation, I'd be reading a lot more podiatry stuff, because I think you've always got to be just improving.
Well, you can have all that podiatry, all that medical knowledge, but if people aren't coming in your door, they're not benefiting from all your hard work. So the marketing part's irrefutably important.
My goal is, if I can learn more about business, more about marketing, more about communicating with patients and being able to get your message across to them, if I spend my time doing that, then that saves the people that come along to my events. You don't have to spend the months of reading all these books. I'm just going to give it all the information to you in one day, and then you can go back and actually apply that.
Excellent. You said something else that reminded me of a thing Dr. Ganley used to say frequently, which is, if the student doesn't surpass, the teacher has failed. So I don't know if that was his quote, but it's a great one. I love watching my former residents go on to great things, and I think it reflects very positively on our teaching program, but also on their dedication and their drive and their initiative to go on to make their own careers. But yeah, it's like having three new children every year.
I think it's a really good
Watching them
point.
grow up.
Yeah, I remember I've had a number of podiatrists that came and worked for me who went off and set up their own businesses and did other things, and they did far better and did a lot more than I ever did with my own practice. But even some of my coaching
Then you
clients,
did the right thing.
Yeah, I look at some of my coaching clients who, at the ages that they are, have doubled what I ever did in my practice at that same age. And I'm just like, it actually makes you feel really good.
It's irrefutable success. You did a good thing.
So back to your career. So is majority of your career all based around pediatrics?
No, it's a significant part of my practice. Probably 15 to 20% is pediatric.
I'm so glad you said that. Is
Uh-huh.
I'm always a bang on the drum about find your niche. Find something in podiatry that you love doing. And the more you can entwine that into your day, the more you're going to just enjoy going to work each day. But it doesn't need to be 90% of what you do. It doesn't,
Well,
it's probably not even going to be
this
50%, but 15 to 20% is a great percentage.
It's that 80-20 rule Dr. Ganley used to always mention. He said
Yeah.
80% of your effort goes into 20% of your patients, and vice versa. There's 20% of your patients that are going to require 80% of your efforts. And that's just the way that things are. Now, we were talking about the nichemanship. I actually published a paper with Podiatry Management or Podiatry Today, one of those two magazines, on nichemanship and specifically addressing pediatrics
Okay.
and how there's no competition. Dr. Ganley used to say children are loud, smelly, and wet, and their parents are usually poor. So it's not like everybody wants pediatric patients.
That is so
But,
true. That is so true.
but they're my favorite patients. I know why they're there.
Yeah.
Some of my adult patients want time off work. They want to sue somebody. They want drugs. They may not want to get better.
Yeah.
Every single one of my pediatric patients wants to get better. And that's very encouraging. Not always the case with adults.
It's true. I do recall you having a lot of children coming through the clinic. I want to get back and playing football. I want to be playing soccer. They just wanted to be out of pain because it was interfering with their life. And they give you honest answers. How did you make some of them? How'd this go? It was horrible. They don't care about your feelings either. But I will admit, some adults, yeah, you question sometimes, especially if it was an insurance claim, and you'd be saying to them, I don't think what you've got here is related to what the injury you had. And
Mm.
that's not the answer. That was the incorrect answer.
Not what they wanted to hear. Yeah.
Yeah. And so I can understand your appeal in that area. But you did the article on niching, did you, about niching into that area?
Yep. I said, look in your community. There's some service related to foot and ankle medicine that is underserved or neglected. At the time I started, and up until just a year or two ago, I've been the only podiatrist at our children's hospital, on the children's hospital medical staff. I applied for privileges many decades ago. There was some questions
Yeah.
about why does a podiatrist need privileges at a children's hospital? And does this exist anywhere else? And one of the only other children's hospitals in the country that I could find that did have a podiatrist was Children's Hospital in Cincinnati. And the podiatrist there was kind enough to write a letter and say, yep, I have privileges here. Here's what I do with them. And I got my privileges. And I do little blocks of surgery there throughout the year. We'll go months with no pediatric surgery cases, and then we'll do 5 in a day. It's like an ice cream shop. They all come at once. But another niche that we haven't talked about yet, and I wanted to touch on, is these patients with connective tissue disorders. That's something I stumbled into. The second annual meeting of the Ehlers-Danlos National Foundation
Mm.
was at a local hospital where I was on staff. And a colleague, Dr. Pat Alessino, who was an orthopedic hand surgeon, had also been a naval officer, and he put an actual 3x5 card on a bulletin board at the hospital. That's how we used to communicate. And it said, there's a meeting of the Ehlers-Danlos National Foundation at this hotel in Chesapeake, Virginia on Saturday. And so I showed up, and I sat in the back of the room, and I was listening, and everybody was complaining about foot problems. Pat came up to me halfway through and he said, "Are you interested in this?" And I said, "Yeah, I remembered hearing about it as a student. I assumed that they had foot problems. I had been in practice for about 5 minutes, so I didn't have anything to do. So I said, yeah, I'm interested." And we actually went to a hotel room and did punch biopsies on the shoulders of these patients and sent their tissue off to a Dr. Byton up in Seattle, who was and probably still is one of the world's leading authorities on connective tissue and the ultrastructure. And he's looking at these specimens under an electron microscope and such.
Yeah.
So and not probably the way research would be done today, 30 years later, but
So is this real? This is very early on in your career, though, that you got
yes, sir.
involved in this. Yeah. So this isn't something that's just more recent. This is something you've done over the last 30 years as well.
Yes, sir. I've been affiliated with Ehlers-Danlos organizations since really the inception, like as I say, the second annual meeting of the EDNF. Now, the EDNF later morphed into the Ehlers-Danlos Society, currently based in London. It's an international, large international organization now with some incredible geneticists and rheumatologists. And I sit in the corner of the room, intimidated by the brain power in the room. And I'll apologize for, hey, I just take care of their feet. All this other stuff's fascinating, but and they'll say, no, patients actually like you. You know, these guys are always poking and prodding and researching them, but I make their feet feel better, so they like coming to see me. And we do have people come to our private practice and our teaching program from all around the world. We developed a couple of procedures that seem to help them,
Yeah.
and we've learned a lot, mostly on the job. There isn't, again, enough data in that area to know exactly what's right to do. And we do consider the connective tissue disorders all to be on a spectrum where you might have the same chromosome as another patient, but your phenotype, your expression of that chromosome may be very different. But just almost 100% have foot problems.
When you're talking about coming up with a procedure, You would have done a number of procedures previously. So do you get together with other podiatrists, you sit down and go, I was wondering if, and you take them through a process and what you're thinking of based on everything you've done in the past, and then they share, well, we've done something similar and modified it here. Then you all agree that we're going to try this.
So that's one method, and we certainly have gone that direction. The procedure that is probably the most common one we use is a replacement of the medial collateral ligament of the first toe. You hear about bunion operations and the
Yeah.
relatively high failure rate, and it's disconcerting, and everybody's always trying to find the best bunion operation. I'd submit that there is no best bunion operation. There are several different things we might call a bunion at different levels on the
Mm.
first ray that might require different types of treatment. But one thing that happens all too often is the big toe can just flop back over.
Yep.
And if you have incompetent ligaments, and this is an idea I got from Dr. Ganley also, was that if a ligament is already stretched out of shape, like the medial collateral ligament of the first toe, why would you trust it to hold the toe straight? It's already failed once. So a lot of bunion operations include a capsulorrhaphy or a tightening of that medial capsule to hold the toe straight. But this is a ligament that's already demonstrated itself to be incompetent. So we've been replacing the ligament with suture and bone anchor devices, and we've experimented with different types to try to find the best fit. And we've done many of these over the last 8 or 9 years. We published a number of posters at different national conferences, and we think we've got it pretty well refined now where it could augment just about any other bunion operation. And we've been using it in people who don't have connective tissue
Yeah.
disease more routinely now. And I think I bet 3,000 years from now, archaeologists are going to dig up a bunch of people around Virginia Beach and they'll have perfectly straight toes.
Well, you've seen that thing in Egypt. They found that toe prosthesis thousands and thousands of years ago, and that did the rounds everywhere.
How about that?
Yeah, somebody came up with that 3,000 years ago, and probably at the time went, "Hey, what do you reckon about this?" And they've gone, "It's not bad."
The
But
tricky thing about these niches is that in children and in people with connective tissue disorders, you have to learn a lot of internal medicine too. Pediatricians are probably the most poorly paid and most sophisticated internists. In order to treat pediatric foot and ankle problems, I think you're obliged to learn a lot about kids. You need to know about medications that may not be appropriate for children or appropriate doses, how usual childhood diseases may impact foot and ankle problems. And we had one patient where a child had strep throat and developed erythema nodosum on the foot. And no one could figure out why this child had these painful skin lesions on their foot. And it was an autoimmune response to their strep throat. So something that you wouldn't pick up on if you didn't spend some time studying about children in general, not just their foot problems. And in the patients with connective tissue diseases, this is especially true. Connective tissue connects every cell in your body to the next cell. So if you have a hereditary or genetic flaw in your connective tissues, you can have dysfunction in every organ system.
makes sense.
So you need to know not only that these people are going to have a special pathomechanical foot that doesn't necessarily pronate, but it sags, but you also need to know that they might have postural orthostatic tachycardia syndrome. If you're trying to fix that flat foot or fix that bunion, you need to know that their blood pressure may fluctuate. So you speak with the anesthesiologist about that. You need to know how careful we need to be moving the patient so we don't dislocate their shoulder or something. They can have dysautonomia and have their temperature suddenly change. They have mast cell activation syndrome where they seem to be allergic to everything. Only one of our former directors of our medical and scientific board of the Ehlers-Danlos Society said to me that in order to take care of people with connective tissues, you just have to know everything about everything. And I said, well, I'm a carpenter,
Yeah.
maybe a cabinet maker on a good day. But I don't know everything about everything, but I endeavor to know enough about diseases of childhood, diseases or comorbidities of connective tissue disorders to take proper care of these patients' foot problems with a broader perspective on their general health.
But I like what you said then, just about you being a carpenter, for example. But I think even people in the trades, they know their trade. And they might have seen an electrician do enough work to figure out there's certain things I know I could probably do because I've seen them do it 10, 15 times. But I think the skill is when you know your limitations and you know when you need to bring in that expert to do the wiring, bring in that guy to do the plumbing. You might have seen him do the plumbing before. You could probably dig a couple of pipes, but you know you're a carpenter. Bring in the plumber when you need him. And I think that's in healthcare, it's really important where, not that I'm saying that we should just stay in a lane, but we know our lane really well. We should know what's in the other lanes, be able to touch upon it, but then know when to draw those other specialties in to help us out. Don't try and do everything yourself.
Great wisdom there. And certainly demonstrated the best demonstration of that in our institution is our patients with diabetes. We have a multidisciplinary approach where every day I'm speaking with a vascular surgeon, often with a plastic surgeon, sometimes with an orthopedic surgeon, often with their endocrinologist, often with their infectious disease specialist, and we're all working together to try to keep them from losing that leg. And we don't call what we do wound care. We have
Yeah.
a wound care clinic, and it's certainly part of it, but that's just one of the parts. We call it limb salvage, and we're trying really hard to prevent limb loss. The data is old, but I've heard that 5 year survival rates after diabetic limb amputation are only about 48%, which is worse than breast cancer, prostate cancer, and lymphoma put together. So we're fighting a very important fight.
What I think is really important, everything you've said, is you run your practice, you're doing some teaching as well. And this is what I said to Patrick to hear. When I looked through his career, all the things he'd done in his career, I was like, how did you fit this all in one lifetime? And when I look at what you've done with everything you've done in pediatrics and all the other interests that you've had over that period of time, and you still surf, you still made time for surfing. I just think that's incredible.
Well, maybe I just have ADHD like a lot of Americans. I mean, we were kicked out of all the civilized countries, right? You look at the founding fathers of America, they were scientists,
I know.
farmers, warriors, all at once. They couldn't sit still.
I know. I look at Ben Franklin and you see just all the different things that he did in his career. It just makes you wonder how they actually fit everything in. So I'm just going to point out to people, if you've been listening to this podcast all the way through up to here, that we have had a few internet problems. While we've been doing this, we've been dropping in and out. So if sometimes all of a sudden it's got to a point and it's paused a little bit, that is the reason why. And plus, something else I want to point out is Patrick does need to go surfing this afternoon. And because of the interruptions with the internet, we've basically been talking a lot longer than what this recording will actually make it. So Patrick, I want to get you back so we can talk about your military service and what you do with the Navy. So you'd be cool to do that?
I would love to do that. I'm planning in retirement to write a book on podiatrists, at least in the Navy and maybe in the military in general.
Yeah.
There are some amazing stories of what people have done. Can't wait to do that. And I've been researching it all along and I'm no professional historian.
Yeah.
Mostly what I know is virtually folklore, but I'm trying to get the references and the actual facts from the horse's mouth while my memory still works and while these people are still alive and can tell their stories, because there are some great ones out there. Certainly my military experience, I wouldn't trade for anything. I saw things I never thought I would. I had opportunities I never thought I would have. It's definitely something I would love to talk about.
Yeah, I think that would be fantastic as a separate thing. I thought we'd work our way through it on this episode, but because of all the interruptions, but the pediatric stuff was too interesting to just brush over it. And I know there's a lot of podiatrists who are interested in that area. And I think some of the things you've done or some of the things you've said are probably going to inspire them to look into it a little bit more. And I must admit, I had a fear of pediatrics. I'd have kids come in and I'd treat the simple ones. And I really enjoyed doing that. But I did have a slight fear in that area because I thought, I don't know enough. But you've already pointed out after 30 years, you're still learning about that area of podiatry. So I think if there's anyone who's had an interest in that area, Just accept it that you're not going to know it all, and it's an ongoing process.
Wise words. Yeah. Good. The good news is nobody knows enough.
Yeah.
And that there are ways to learn more. There are resources.
Yeah. And if anyone says they know everything, they're lying.
Absolutely. Yeah.
That is great. So, Patrick, I want to thank you for coming on the Podiatry Legends podcast. I apologize for whatever's gone on with the internet today, but you know what? That's life, and we still got through it, and we're still both smiling, so it doesn't really matter.
It's been a privilege. Thank you.
Okay, and I look forward to talking again very soon.
Awesome.
Well, I hope you enjoyed listening to Patrick Agnew today, and here's something that really stood out to me, and I hope it did for you as well, was his honesty and humility. I thought it was amazing. He is someone who's been in the profession for over 30 years, and he is still learning, still evolving, and still passionate about what he does. That's the kind of mindset that I believe all of us can aspire to, whether you're just starting out or you are decades into your career. And if you've ever felt unsure about treating kids or diving into a more complex niche, I hope this episode gave you the confidence to at least start exploring it. Remember, it doesn't have to be all or nothing. Even 15, 20% of your work focused on an area you love can reignite your passion and make every day in your clinic more rewarding. And as I always say, if you enjoyed this episode, please share it with your podiatry friends, share it within your networks. And if you're looking for a business mentor or coach to help you find your niche and build your practice, build a practice that you love, feel free to reach out to me. Just go to my website, tysonfranklin.com, click on the coaching section and just read through the information there. Then we'll organise and just have a bit of a talk. So anyway, that's it for me this week. I want you to look after yourself, look after your family, and I will talk again next week. Bye for now.